اي دكتور، واضح واضح دكتور.
Okay. Okay, the meeting today is on essential genetic diseases of bones and joints. I'll tell you, this is a requirement that we request that our orthopedic training program to consider them seriously. Because I'll tell you something. You say, oh, this has nothing to do with cold and reconstructive surgery. I'll tell you, no. It is a big embarrassment when you receive a patient who has a genetic problem and you tell them, I don't know, and you try and find another specialist to try and solve the problem. Ya Jama'ah, in the training program, you have to know everything in orthopedics in the first 5 years. After 5 years, you are free to choose whatever subspecialty you want to have. But before it, you are responsible. And this is, believe me, very important. And on a day-to-day basis, I have referrals asking me to try and identify what the patient has. Okay, so please keep this in mind. Now we're going to start with the lysosomal storage diseases. They are a large group of genetic disorders, some of which cause secondary osseous abnormalities due to intraosseous accumulation of insufficiently catabolized cellular products. These conditions occur when you have deficient enzymes to break up the products within the cell so as to be able to be digested. And these accumulate in the cell, and the disease is the result. These diseases are characterized by a defective synthesis of lysosomal enzymes necessary for intracellular digestion of either cellular breakdown products or phagocyzed extracellular material. So in other words, you cannot get rid of the material which is present within the cell. So you have an accumulation of the material. Okay, so let's have this clear from the very start. Now, the affected lysosomal enzymes are not synthesized or do function, or they don't function normally. As a result, the product usually digested by that enzyme, it accumulates inside the lysosomes and greatly interferes with cellular function. The distorted cells often interfere with the function of adjacent unaffected cells. So keep this in mind. This is the basic knowledge you should know about these conditions. Most of these storage diseases are autosomal recessive. Meaning, what do we mean by autosomal recessive? It tells us that the disease is only expressed only in the homozygous state. Heterozygous, zygotics, or carriers are not phenotypically affected because one normal allele synthesizes enough enzyme for adequate lysosomal function. However, heterozygotes can be identified by assays which demonstrate reduced levels of the enzyme. And if you have two genes, two alleles, and one is intact and the other is not, the disease is not fully expressed, but you can still identify it by a special analysis. There are about a dozen well-defined lysosomal storage diseases. Each disease targets the organs rich in the product, which cannot be degraded properly. The affected cells in each organ are those which contain lysosomes, and macrophages having many lysosomes are most vulnerable. Therefore, tissues rich in macrophages, such as bone marrow, lymph nodes, spleen, and liver, are usually severely affected in the lysosomal storage diseases. Bones and joints are secondarily affected in some lysosomal storage diseases. Two diseases, Gaucher's disease and mucopolysaccharidosis, are complicated by severe bone or joint involvement. The bony changes of Gaucher's disease are due to the accumulation of abnormal macrophages in the bone marrow. The mucopolysaccharidosis result also from accumulation of insufficiently degraded glycosaminoglycans. At first, we used to speak about mucopolysaccharides, but at present, we speak about the glycosaminoglycans which accumulate in the mucopolysaccharidosis, or these diseases related to the storage of mucopolysaccharidosis. So now let's come to Gaucher's disease. If you see in this slide, you see that the cells are large, the Gaucher's. They are larger than regular cells, larger than macrophages. So these have an accumulation of a cerebrocyte, which is causing the disease. Through its pressure, you can have multiple diseases. This is a hip problem that we deal with quite often. And this occurs in Gaucher's disease, osteonecrosis of the hip. The difference between another form of osteonecrosis is that it usually occurs at the same time, and it's quite common to be present in children. And we think that it could be like Calvi-Percy's disease. But when the degree of involvement is similar on both sides, you should think of Gaucher's disease. This is another case showing you the pathology and the necrosis of the hip. It fits with the rest of the stages that we have for osteonecrosis, but it usually involves both hips at the same time. These are pathologic specimens showing the accumulation of Gaucher's cells. We think that it is through the pressure of these cells on the structures around it that gives us the pathology. Gaucher's disease is an autosomal recessive disorder. It's characterized by accumulation of glucocerebrocytes in macrophages throughout the body. Why? Because we don't have the enzyme that breaks down the glucocerebrocytes. Glucocerebrocytes are breakdown products of senescent blood cell membranes and are normally digested by the enzyme which is called glucocerebrosidase, a lysosomal enzyme which cleaves glucose from cerebrocytes. So it's an easy disease to remember, but you have to remember the glucocerebrosidase, which breaks down the glucocerebrocyte and separates the glucose from the cerebrocyte, and as a result, we don't have this. So this accumulates in the macrophages. Gaucher's disease is caused by a mutation in the gene located on the chromosome 1q21. This synthesizes this enzyme. Okay? As a result of mutation, we no longer have this product. As a result, patients have low levels of glucocerebrosidase. So we end up by having abnormal macrophages. These are the principal pathologic features of Gaucher's disease. These abnormal macrophages, known as Gaucher's cells, accumulate in the bone marrow, liver, spleen, and lymph node. There we have a huge amount of macrophages, and it accumulates, and it gives us the various clinical presentations. The cytoplasm is engorged with material, which with routine histologic preparation resembles a crumpled tissue paper and reacts strongly with PAS stain. With the electron microscope, this intracellular material corresponds to stacks of bilayered membrane within elongated lysosomes. This is a photomicrograph, again, of a Gaucher cell in the bone marrow. You see these are huge cells occupying the bone marrow. These are what causes the disease. These are what causes pressure on structures. These are what causes the avascular necrosis of the hip when it does occur. It is not rare. A genetic clinic at a university hospital may see 2 or 3 new cases per year. Although the abnormal gene has a high frequency in Jews of European origin, the disease occurs in all racial and ethnic groups. What are the types that we have? Or what are the clinical presentations that we have of the type 1? Its most common symptoms are splenomegaly, hepatomegaly, bone diseases, thrombocytopenia, anemia, growth retardation, bruising and bleeding, fatigue, bone pain crisis, and abdominal pain. So, it's characterized by a wide range of clinical severity, a reflection of different point mutations in the glucocerebrosidase gene. However, 3 major phenotypes are recognized. Most patients have type 1. In this form of Gaucher's disease, signs and symptoms don't appear until adult life. In types 2 and 3, these are infantile and juvenile presentations. These patients have severe disease, and many die with neurologic involvement. Clinical features of Gaucher's disease are due to accumulation of Gaucher's cells. I repeatedly tell you this so that you will never forget it. In organs rich in macrophages, the liver, spleen, and bone marrow. This is a repetition for memory's sake. As a result, patients present with hematologic problems and bone lesions. What about the hematologic problems? They have pancytopenia or thrombocytopenia. They are usually mild and are due to bone marrow replacement and hypersplenism. The bone lesions due to marrow infiltration by Gaucher's cells may lead to severe complications. What about the skeletal manifestations of Gaucher's disease? There are three principal skeletal manifestations of Gaucher's disease. Gaucher's cells compress the intraosseous vasculature and cause osteonecrosis in 55% of patients. Usually the femoral head is affected. Don't forget this. This shows you it. Both are symmetrical. It involves both hips. It can be present later on in life, and especially the type 1 osteonecrosis. This is a closer view of some of the cases. It does affect other regions, and the deposition of the macrophages in the metaphysis causes it to widen. And in the distal femur, it gives you the Erlenmeyer flask deformity. And this is a deformity where you have enlargement of the metaphysis, full of macrophages, full of Gaucher's disease. The second way bone is affected, Gaucher's disease, is the development of modeling deformities. And this is a modeling deformity due to intraosseous accumulation of abnormal macrophages. It does affect the shoulder. And you should distinguish this from other causes like Caisson's disease. You have to keep this in mind. This is another shoulder, proximal humerus, which is involved. Modeling deformities, as I mentioned, are most evident in long bones, particularly at the distal end of the femur, and this resembles an Erlenmeyer flask deformity. The third osseous manifestation is the development of large lytic defects filled with Gaucher's disease or Gaucher's cells. This shows you on the right-hand side, as you're looking at it, in enlargement of the distal femur. This is what we call a reversed Erlenmeyer flask deformity. There is definitely cortical thinning and expansion of the bone. This is due to the deposition of the Gaucher cell within the metaphysis. These lytic lesions are often complicated by pathologic fractures or insufficiency fractures. This is secondary to cystic degeneration. The extent of all these osseous manifestations is best visualized by MRI scans. This is an MRI scan of a patient with Gaucher's disease. You can see a zone of lysis. You can see an accumulation in the proximal tibia of Gaucher's cells. So keep this in mind. The treatment of Gaucher's disease is supportive. Managing the orthopedic complications is one of the most important aspects of supportive care. Promising results have been achieved in some patients by intravenous infusion of the missing enzyme, glucocerebrosidase. So much for Gaucher's disease. Now we come to a set of new forms of deposition diseases, the mucopolysaccharidosis. They are a group of lysosomal storage disorders. They are caused by deficiencies in the enzymes which catabolize glycosaminoglycans, formerly known as mucopolysaccharides. So there's a change. We don't longer say that the deposition material is mucopolysaccharides. It's a glycosaminoglycan, which is deposited. Because hyaline cartilage is rich in glycosaminoglycans, it is one of the tissues affected in these disorders, and skeletal deformities result. Glycosaminoglycans are long-chained, unbranched molecules composed of repeating disaccharide units. 4 major types exist: chondroitin sulfate, keratin sulfate, heparin sulfate, and dermatin sulfate. Multiple glycosaminoglycan molecules, when attached to a protein core, form a proteoglycan molecule. I know this is confusing, but think of it, and it doesn't take much to remember them. Proteoglycans are an important component of extracellular matrix of various connective tissues for 2 reasons. They contribute to tissue resiliency by their ability to trap water. We all know that they imbibe water. For example, the resiliency of articular cartilage is due to high concentrations of proteoglycans. The importance of proteoglycans is their function as a medium for transmission of cell-to-cell messages. The integrity of the extracellular matrix is maintained by a constant turnover of proteoglycan molecules. New molecules are synthesized and old molecules are degraded. Part of the degradation process of proteoglycans involves enzymatic cleavages in the various glycosaminoglycan chains. At least 10 steps, 10 enzymes are required to catabolize glycosaminoglycans. Genetic deficiency in any of these 10 enzymes results in accumulation of the substrate. The same applies to Gaucher's. A deficiency leads that there's a lack of catabolism, and therefore, instead we have an accumulation, and these cause the diseases. Various clinical phenotypes depend on which substrate accumulates. Not only does the particular substrate accumulate in tissue, but excess amounts are excreted in the urine. So we can detect them by examining the urine, a feature which aids in distinguishing the various phenotypes. All the mucopolysaccharidosis share a common pathogenesis. The particular glycosaminoglycan accumulates in lysosomes and causes cellular dysfunction, just as what occurs in Gaucher's disease, and often results in cellular death. As with most of the lysosomal storage diseases, the cells most vulnerable are those rich in lysosomes, particular mononuclear phagocytes, macrophages. Other affected cells include the granulocytes, endothelial cells, smooth muscle cells, and fibroblasts. The organs most severely affected in each phenotype are those, again, richest in the particular glycosaminoglycan, which cannot be degraded. The mucopolysaccharidosis also share common pathologic features. The affected cells in all syndromes show cytoplasmic flaring and are called balloon cells. This feature results from numerous cytoplasmic vacuoles, which with electron microscope correspond to distended lysosomes. There are 6 major phenotypes of mucopolysaccharidosis, and these have been described: Hurley syndrome, which is the most severe, Hunter syndrome, Sanfilippo syndrome, Morque's disease or Morque's syndrome, Marito-Lamy syndrome, and Sly syndrome. All these are autosomal recessive, with the exception of Hunter syndrome, which is X-linked. Each syndrome is associated with specific enzymatic defects, which result in accumulation of excretion of either heparin sulfate, keratin sulfate, dermatin sulfate. A few of these syndromes exhibit a spectrum of clinical severity, probably due to different point mutations in the affected gene. What are the general clinical features? Although the phenotypes of mucopolysaccharidosis are quite variable, but they share numerous clinical features. Infants appear normal at birth. Keep this for the pediatricians. They appear normal at birth. Abnormalities usually become apparent by the age of 2 years. Varying degrees of mental retardation are present in most syndromes. Cardiac anomalies are common, and there is usually hepatosplenomegaly. They have coarse facial features. These definitely are present except in Morque's syndrome, and there is usually corneal clouding. A number of these end up blind. Growth retardation sometimes is severe, and this is present in all syndromes. Skeletal complications of these conditions. Osteoarticular abnormalities are also present in the mucopolysaccharidosis. The common pathogenesis of these syndromes causes a shared pattern of skeletal changes known as dysostosis multiplex. This is a group of skeletal patterns that are present in all. Dysostosis multiplex is an abnormality of the spine. The vertebral bodies are oval. They are diminished in height or flattened. In addition, if you look at the lateral view, you see that there is anterior beaking of the vertebral bodies. These vertebral abnormalities usually lead to kyphoscoliosis with a pronounced gibbous, meaning a kyphus. In the cervical spine, the dens is sometimes hypoplastic, a feature which may lead to instability. Abnormalities of the pelvis is another feature. The acetabular roof is poorly developed, and there is flaring of the wings of the ilium. Also, the femoral heads show varying degrees of dysplasia. And because of the poorly formed acetabula, the femoral heads may dislocate. Coxa valga is very common. This is a plain radiograph, which is one of the skeletal manifestations of the dystosis multiplex. This is a patient who has Morque's disease. Look at the dysplastic acetabulae and the marked coxa valga with dislocation of both hips in Morque's disease. Look at the pelvis. Look at the ilium. It's flared. It is opening its arms to you. It's flared. It's broad. You have also long bone changes. This could be severe. And again, this is a component of the whole multiplex. The bones are expanded and the cortices are thin. Usually the epiphyseal ends are malformed, which in the knees results in genu valgum. Also a constriction of the humeral and femoral necks is often present. Look at the deformities. This is a patient who has Morque's disease. You see the genu valgum, the dysplastic epiphysis, is present from one side. Other bones are involved. If you take an X-ray of the phalanges of the hand, they are short and wide, and the metacarpals are tapered proximally. In the skull, the scalvarium is thickened, and sclerotic changes occur in the mastoid bone. Putting together all these findings, putting them together, you might be able to identify the disease and satisfy everyone about you. Coming to the specific phenotypes, of course, I spoke to you about they share a common pathogenesis and many features. Let's come to Hurler's syndrome, which is the most severe form. So you have to think of this. This is a summary of what you can see with Hurler's syndrome. You can get spinal abnormalities. You can get claw hands, gross retardation, deafness, heart valve abnormalities, thick facial features. They have joint stiffness. The corneas, which may appear cloudy in appearance and later may end up with blindness. Again, there's a defect in the enzymes that produce the defect. It leads to accumulation and increased urinary excretion of both dermatan sulfate and heparin sulfate. Children with Hurler's syndrome have a severe skeletal abnormalities. They have progressive neurologic deterioration. They have cardiopulmonary disorders which lead to death almost always before the age of 10. In addition, these children have a short stature and they have a coarse facial features. A different mutation in the same gene affected in Hurler's syndrome leads to a much milder disorder. This syndrome is called Shy's syndrome. It is characterized by a normal lifespan and normal intelligence. Hurler's syndrome patients excrete heparin and dermatan sulfate, although in much reduced amounts. And these are photographs of various cases of Hurler's syndrome Hurler-Scheie syndrome, which is less aggressive than Hurler's and Scheie syndrome. And you have to look below. These are the abnormalities you could have with these conditions. The Hunter syndrome, which is mucopolysaccharide 2, is the next major form, and which Charles Hunter reported in 1917 was the first to describe it. A mild and a severe form of this disease are recognized. Look at this patient. This patient has Hunter's disease. طلع بوجهه. He has a broad forehead. He has thick eyebrows. He has a broad nasal base. The nostrils are large. The ears are low set. And they have a large tongue. The development delays in these conditions, I'll tell you, these are the various abnormalities which are repeatedly present in these conditions, but they are common to all. They are similar, and nonetheless, most patients die between 10 and 20. Like Hurler's, both heparin and dermatan sulfate are excreted in the urine. Unlike the other mucopolysaccharidosis, which are autosomal recessive, Hunter's syndrome is X-linked recessive. If we ask a question, which of the mucopolysaccharidosis is X-linked recessive, you should point out Hunter's syndrome. The third major is Sanfilippo syndrome, which is MPS 3. They have profound mental retardation, which characterizes this syndrome. Look at this face. Doesn't he look to have a high IQ? No, he doesn't. He is not intelligent, but he has the same features. Look at the nose. Look at the eyebrows. Look at the low-set ears. Look at the wide frontal portion of the head. In addition to the skeleton, the heart may be mildly involved, but patients survive to adulthood. This phenotype is caused by mutation in one of the 4 genes and leads to an accumulation of heparin sulfate. Clinical severity varies depending on the gene affected. I tell you this, and this is mentioned to the residents. These conditions are taken seriously abroad, in USA, in Canada, in England. Quite a number of questions occur on these topics. You have to know which is deficient and which is in large amounts present in the urine. Which one is autosomal recessive and which one is dominant. These are basic teaching. You should know about the clinical features of each of the conditions. We see quite often, I've seen several cases in my lifespan of Morquio syndrome. MPS 4 is characterized, like most of the other mucopolysaccharidosis, by short stature. As a matter of fact, one of my classmates had Morquio's disease, and they have severe skeletal abnormalities. Because patients with this syndrome usually survive to adulthood, orthopedic surgery is often required to stabilize the spine and reconstruct the joints. These are 2 lovers who have Morquio's disease. Look at the teeth. The teeth is abnormal. Look at the nostrils. They are wide. Look at the base of the nose. It's depressed. Okay, and they have large tongues. This is another group, Morquio's disease. They also have deformities, ginovalgum, and others. Look at the spine. Height of the vertebrae are decreased. We call it platyspondyly. And they have beaking of the anterior edge at the site of the pointers. Okay, so these are the abnormalities, and these patients have a thoracolumbar kyphosis. They have hip problems, just like other conditions, like Gaucher's disease. Look on the extreme right-hand side, you see that the metacarpals are short, and this is typical of these conditions. Look at the chest. The clavicle is more bulky. The scapula is not so well formed. Look at the ribs. They are horizontal. They have a paddle-shaped ribs. This is a larger view of the hands. You see that the metacarpals are short. The phalanges are shorter than normal. Look at the deformities in the knee. You have ginovalgum and completely distorted epiphysis, leading to degenerative arthritis. In a number of cases, we had to replace the joints. Also, don't forget that the organs are involved, the heart and the lungs, unlike the other mucopolysaccharidosis, which are characterized by coarse facial features. Fine facial features characterize Morquio syndrome. Morquio syndrome results from either of two different enzyme defects, both of which lead to an accumulation of keratin sulfate, and you see it in excess in the urine. You have the Merito-Lamy syndrome, which is MPS 5, and this is the fifth component. The patients with this syndrome excrete excess amounts of dermatan sulfate. Like patients with Morquio syndrome, patients with this syndrome often survive until adulthood and therefore require management of the dysostosis multiplex, meaning the multiple deformities and defects. Unlike the Morquio syndrome, however, coarse facial features are characteristic of Merito-Lamy syndrome. Patients with this syndrome excrete excessive amounts of dermatan sulfate. Keep this in mind. Know which of the conditions excrete more from one of the four components, whether dermatan sulfate or whether any of the other forms. This is what these patients have. They have a short stature, they have intellectual disability, they have coarse facial features, they have hepatosplenomegaly, they have corneal clouding and some become blind, they have leukocyte inclusions, joint contractures, and dysostosis multiplex. This is a patient who has these findings. You see that they have adenotonsillar hypertrophy, macroglossia, a large tongue. They have a limitation of mandible mobility, of jaw mobility. If you look at the cervical spine, they have shortness of the neck. They have atlantoaxial instability. They have spinal cord compressions. They have the short neck I mentioned about. They have limited neck mobility. They have laryngeal distortion. Looking at the heart, they have cardiomyopathy, valvular diseases, commonly mitral and or aortic valve. They have tracheobronchomalacia. They have distorted tortuous, compressed trachea, restrictive lung disease, obstructive lung disease, thick secretions, and they consist of a short stature. They have scoliosis And if you take a photograph of them without clothes, you see they have a pectus carinatum, meaning the whole sternum is forwardly displaced. Look at the teeth of these patients, and you see behind the upper jaw, you see a large tongue. The last is Sly syndrome, or MPS 6 is the rarest of this group of disorders. Patients have clinical features similar to the other forms. Sly syndrome or MPS 7, they have a deficiency of beta-glucuronidase, they have hydrops fetalis, and this is a common presentation. And the clinical features are similar to MPS 1, and they have dysostosis multiplex, just like the rest, and corneal clouding. These patients have a short stature, they have hepatosplenomegaly, and they have mental retardation. Varying degrees of clinical severity characterize this disorder. A deficiency in beta-glucuronidase leads to the inability to catabolize dermatan sulfate, heparin sulfate, and chondroitin sulfate. So much for the mucopolysaccharidosis. This is the first section. I have two other sections, which I'll be talking about. Now we're coming to the second section, which is a condition that we often see in our clinic, alkaptonuria, or an easier term is ochronosis. Alkaptonuria is known as ochronosis. It is another genetic disease which indirectly affects the skeleton. Often, I say often, not much, we get a family calling us saying, "Doc, our child always has black diapers are black." Or when they reach adolescence, they call us, they say, "When our child is playing around and he sweats, and his sweat is black, what does he have?" This disorder is characterized by black urine and in later life, severe arthropathy. Why? Because a certain substance deposits in the cartilage and causes it to become brittle, it becomes black, and it fragments. Even in the pinna of the ear, you see that there is a black deposition of pigment. Even in the sclera, you see that there is deposition of pigmentation. Even in the disc, you see the disc spaces are degenerated and they are black and deposited. Even in the hands, you see the hands become black. So, what causes it? It is caused by an enzyme deficiency, resulting in the inability to catabolize homogentesic acid. This is an intermediary compound in the metabolism of tyrosine and phenylalanine. If you look at phenylalanine, tyrosine, when it changes to homogentesic acid through 4-hydroxyphenylpyruvic acid by the action of the acid deoxygenase. It leads to this product, and it would prevent a black deposition. Okay, so it's due to a homogentesic 1,2-dioxygenase absence. Okay, so the genetic mutation really is not known, but we know that it causes a deficiency in homogentesic acid oxidase. As a result, large amounts of homogentesic acid accumulates in the tissue and are excreted in the urine. Therefore, oxidation of homogentesic acid, both in the urine and tissue, leads to this black pigmentation. It's a melanin-like pigmentation. This shows you a normal urine and the black urine. When it's exposed to air, it changes to a black, a melanin-like pigment. Homogentesic acid and is oxidized. They are interfered by the lack of an enzyme which causes an accumulation of the component, the melanin-like pigment, which deposits in cartilage, and it becomes known as ochronosis, and this leads to osteoarthritis. And also we have seen patients having black valves. The mitral valve could be black. Humans have long suffered from alkaptonuria. Although patients with black urine were reported as early as 1584, even earlier evidence of this disease, both biochemical and radiographic, has been found in Egyptian mummies. The disease was named alkaptonuria in 1859 because of alkalinization exaggerated the blackening of the urine. Later, in 1866, Virchow called this disease ochronosis after noting an ochre color of the pigment. It is historically significant because it was the first inborn error of metabolism to be characterized. In Garod's study, alkaptonuria led him to formulate the one disease, one enzyme deficiency. Unfortunately, this theory was ignored for many years. Alkaptonuria is rare, but a very high incidence occurs in the Dominican Republic and in the former Czechoslovakia. And this is likely due to the frequent consanguineous marriages in these regions. It may be diagnosed shortly after birth because the diapers are discolored by black urine. Other clinical features are usually delayed until adulthood. These features are due to deposition of pigment in the three major areas: the joints, the cardiovascular system, and the urinary tract. After the onset of symptoms, this disease progressively worsens throughout life. Although patients usually have a normal lifespan, the symptoms can be crippling. The cardiovascular and urinary systems are involved in alkaptonuria, but clinically problems are not severe. The pigment is deposited in the cardiac valves and in the intima of blood vessels. The latter often leads to premature atherosclerosis. In the urinary tract, calcified ochronotic pigment leads to renal or prostatic calculi. Sometimes these calculi cause urinary tract obstruction. What about the skeletal changes? Look at the spine. Look at, you see the discs are narrow, secondary to the degeneration of cartilage, secondary to the deposition of melanin-like pigment. You see the vertebra appears as one stiff block. You should distinguish this from ankylosing spondylitis. The orthopedic problems usually begin in early adulthood and cause the most severe symptoms. The spine is usually the first region to be affected by pigment deposition in the intervertebral discs and paravertebral soft tissues. Patients present with low back pain, stiffness, and nerve root compression. The radiographic features are characteristic. The disc spaces are narrowed and are usually calcified, as I have repeatedly mentioned. This is a plain radiograph, a close lateral view of ochronosis of the spine. There is disc space narrowing and subchondral sclerosis with anterior osteophytes. In addition, traction or extension of the spine often produces a radiolucent vacuum in the disc space anterior to the disc calcification. The intra-articular vacuum, a consistent finding in alkaptonuria, is best seen on lateral plane radiographs. You see over here, the vacuum is being cleared when you apply some traction. You see the vacuum, air in the disc space. Vacuum phenomena involving the intervertebral discs is usually a result of accumulation of gas, principally nitrogen, within the crevices of the intervertebral discs or adjacent vertebrae. This is a joint example of vacuum phenomena. The involvement of large joints, such as the hips and knees, usually begins later than spinal involvement. Dark brown or black ochronotic pigment is extensively deposited in articular cartilage, which grossly appears dark brown or black. This is a gross photograph of ochronosis of the femoral head. Look at the melanin-like pigment which is deposited. This gives it, the cartilage, a brittle character, and it fragments and leads to degeneration, leading to osteoarthrosis. So much of the cartilage is denuded. The cartilage remaining is black due to ochronotic pigment. The pigment can be seen in microscopic sections. The pigment renders the cartilage extremely brittle, and large fragments are shed into the joint, and they become embedded in the synovial membrane. This shows you brown pigment being deposited in the articular cartilage of the femoral head. The pigment is in the lower layers of cartilage. Intense synovitis often results. Ultimately, patients develop severe secondary osteoarthritis, often with extensive intra-articular calcified loose bodies. Although severe arthropathy of peripheral joints may be successfully treated by total joint arthroplasty, spinal involvement produces a severe disability. Patients often require long periods of bed rest. This is enough for ochronosis. Now we come to osteopetrosis. I have seen in my experience of 50 years of teaching and working, I've seen several cases of osteopetrosis. I haven't seen the infantile form. These usually succumb to their condition secondary to pancytopenia and severe anemia, while the adolescent or the late form, we see them occasionally by chance on routine x-rays. So you have to keep this in mind. It is a disturbed activity in the osteoclast. We cannot remodel the bone in these cases, which need remodeling. You don't see osteoclasts in the Hoship's lacunae, meaning the space in which it acts. If you take an osteoclast in this condition, you see the brushboard that does not exist. They have a reduction of the bone cavity. As a result, areas where you have nerves or structures, they become narrowed, and therefore they will have pain secondary to pressure. If we look at these x-rays, you see that the density of bone is very solid. It's all one block. But you should know this does not mean that the bone is stronger. In other words, it is weaker. If you look at chalk that you write on the board, if you hold it and it cracks easily. But if you get a tube, an empty space in the center, biomechanically it is stronger. So you have facial deformities in these patients, the infants. They have a broad face, they have hypertelorism, snub nose, and they have frontal bossing. They have delayed tooth eruption. They have narrowing of the skull foramina. They have failure or resorption and remodeling, which press on the cranial nerves and the optic nerves. You can have atrophy, blindness, deafness, facial paralysis. You can have as a complication osteomyelitis of the jaw, and this can occur as a complication while extracting the teeth. Unlike many skeletal dysplasias which lead to osteopenia, some genetic diseases result in radiodense bones, the most common of which is osteopetrosis. Osteopetrosis is a group of disorders characterized by decreased osteoclastic bone resorption. As a result, the bones become extremely dense, a feature which has led to the name of marble bone disease. مثل الحجر, solid, a whole block of bone. The mandibles are larger. You have an increased density of bone due to lack of remodeling. The face is very special in appearance. The spectrum of clinical severity in osteopetrosis indicates that bone resorption can be inhibited in varying degrees and reflects the complex origin of functional osteoclast. Indeed, osteoclast differentiation and activation is multifactorial and depends on the hematopoietic stem cell competence as well as signals from osteoblasts and extracellular microenvironment. Because of these complex interactions, osteoclast function can be blocked at any number of points, thereby inhibiting bone resorption in varying degrees of severity. For example, in some forms, osteopetrosis, osteoclasts are present even in large numbers but cannot resorb bone. You find that there is no brush border to indicate that there is any resorption occurring. In other forms, osteoclasts are markedly reduced in number or even absent. So in areas you see a huge number, but there are no abnormal, there's no brushing of the border due to pseudopods, which are involved in resorbing bone during the remodeling process while they are in Hosch's lacunae. On the other hand, you see complete absence of osteoclasts, and in other cases, you see osteoclasts which are present in sufficient quantities but are not functioning. In those cases where osteoclasts are absent, excellent therapeutic results have been achieved with bone marrow transplantation, a procedure which delivers competent stem cells. The effect was first noted in 1975 when osteoporotic rats were cured by bone marrow transplantation. This established that osteoclasts are derived from hematopoietic stem cells. By contrast, bone marrow transplantation is ineffective in those cases where osteoclasts are present, but they are paralyzed. As I mentioned, there's no brush border. There's nothing. They are present, but they are inactive. And when you do a transplant, in these cases, there's no response. In these cases, osteoclast dysfunction is probably due to inefficient signals from the microenvironment. Could be from the rankle, which the osteoblasts send to stimulate the osteoclast to function. The molecular genetics of osteopetrosis is poorly understood. Unlike osteogenesis imperfecta, where different point mutations in a single gene result in different phenotypes, the varying clinical severity in osteopetrosis is likely due to mutations in different genes. However, the mutation, I want to see 1 second, sorry, I have to clear. إجا شي بالدرب ما عم بقدر شوفه. يلا ماشي الحال. The exact mutation of most of these, I have في عندي blockage بالscreen. I have to see whether I can solve it. شو البلوكج هيدا؟ بدي شيلها. That doesn't. Okay. They are unable to synthesize macrophage colony factor, which is an important cytokine which stimulates the differentiation of osteoclasts. في شيء مسدد للسكرين. فرجيني كيف بدنا نعملها هي. Okay, I'm going to put it down. شوف كيف فينا نروحها. Okay. Okay, that's good. That's better. We have a macrophage colony factor, which is an important cytokine, which stimulates the differentiation of osteoclasts. Finally, some patients with osteopetrosis encode reverse transcriptase, a viral protein, suggesting that in these families, the mutations originated with a viral infection. What about the radiographic features? The radiologic features of osteopetrosis reflect defective bone resorption, although changes vary in severity in different patients. The bones show diffuse symmetrical sclerosis. The long bones frequently show transverse metaphyseal sclerotic bands. Plain radiograph of osteopetrosis is shown over here with the pelvis. Even though the bone is extremely dense, it is subject to insufficiency fracture, because I repeatedly mentioned that a solid bone is less stronger than a hollow bone. A solid bone where there is no remodeling or increasing bone formation at sites of stress is ineffective. They also show modeling deformities, a feature particularly evident in femurs, which are shaped like Erlenmeyer flask deformities, just like we mentioned about Gaucher's. In addition, the vertebrae frequently have a sandwich vertebra or a rugged jersey spine, appearance due to sclerosis beneath the end plates. This shows you the solid bone with no remodeling. On the right-hand side, you see the Erlenmeyer flask deformity, which is this time dense, indicating a disturbance in remodeling. While Gaucher's disease, it is radiolucent. This gives you the rugged jersey spine due to sclerosis and beneath the end plates. Okay? Other bones, such as the ilium, they show a bone within a bone pattern. The bones of the skull are also thickened and sclerotic, a feature most marked at the base of the skull. We see it in this view. So yeah, over here you can also have some kyphosis at the thoracolumbar area. You see that the femurs are increased density they have. The skull is fully dense and the pelvis likewise. The pathologic features of osteopetrosis are also a result of osteoclast inability to resorb bone. Changes are most evident in the metaphyseal region. Unresorbed primary spongiosa fills the metaphysis and the aphysis with broad streams of calcified cartilage encased by bone. This is a sketch showing you what we mean by osteopetrosis. Bone is not remodeled. Osteoclasts are not able to resorb bone. In our lifetime, we have osteoclasts removing bone and osteoblasts laying down bone according to the line of stress. Biomechanically, the quality of bone is not good. It fractures. It has fragility, even though it is more dense. This shows you the bone, the trabeculae, of how thick it is compared with normal bone matrix. This is a photomicrograph of osteopetrosis. You see, very rarely we see osteoclasts along the trabeculae. They don't exist. There's failure of osteoclastic activity resulting in unrestricted bone in the marrow space. This shows you, look at the trabeculae, look at the osteoid tissue, it's thick. You don't see osteoclasts. You don't see Hoship's lacunae, the site of which osteoclasts act in. The bone is usually woven, although in some instances, lamellar features are present. Why do we have woven bone? Because it is not real model bone. So why? What happened is that there is no remodeling along the line of stress. So the bone is weaker than usual. You get fractures. Electron microscopy. Studies of osteoclasts reveal absence of the ruffled border or the brush border, these multiple brushes that resorb bone through Hoship's lacunae. Don't forget this, please. Three important clinical features of osteopetrosis result from resorptive failure and disordered bone architecture. First, despite very dense bone, the disordered architecture leads to bone fragility. Remember this. Therefore, fractures are a frequent complication of osteopetrosis. Second, obliteration of the marrow cavity causes anemia. And third, impingement of neural foramina in the skull often causes cranial nerve palsy. So don't forget these. In addition to the clinical features related to failure of resorption, patients are also susceptible to osteomyelitis. This feature, caused by a degree of immune incompetence, is probably due to the same defect which inhibits osteoclast differentiation. There are at least 13 forms of osteopetrosis and mutations in at least 10 genes have been identified as causative factors. However, in most patients fall into one of four phenotypes. The largest category includes patients with mild autosomal dominant disease. The mild form of osteopetrosis was the first to be recognized in 1907. Albert Schomburg, a German radiologist, described a 24-year-old man with dense bones and multiple fractures. Osteopetrosis is sometimes called Albert Schomburg's disease after his description. Even within this category of mild disease, variations in severity and varying patterns of skeletal involvement indicate genetic heterogeneity. For example, serum acid phosphatase is elevated in some patients and not in others. The general health and lifespan of patients with mild autosomal dominant osteopetrosis is normal. Indeed, some patients are asymptomatic, and as I mentioned before, they are diagnosed only on incidentally taking x-rays for other causes. Other patients have mild anemia and a history of a few fractures. More severely affected patients may develop osteomyelitis or suffer cranial nerve palsies. In autosomal recessive form of osteopetrosis, known as malignant osteopetrosis, causes severe disease. Patients present in infancy and usually die before the age of 10 years. Severe pancytopenia, hepatosplenomegaly, and cranial nerve palsies are common, as I mentioned at the beginning. There are two forms, one which is aggressive and severe, and these children die early, while in the adult form, they are discovered by chance many times. Patients sustain multiple fractures in these early cases, and they are prone to develop osteomyelitis. Patients have a genetic mutation resulting in very low levels of carbonic anhydrase 2, an enzyme necessary for bone resorption. They lack carbonic anhydrase 2. Patients with carbonic anhydrase 2 deficiency have dense cerebral calcification. They have a condition which is called marble brain disease, a complication which frequently causes mental retardation. Treatment: osteopetrosis has been treated in various ways. Bone marrow transplantation has been used in young patients with severe disease. However, an acceptable donor can be found for only 40% of patients. Following this procedure, 45% of patients survive, and half of these are cured completely of the disease. Alternatively, some patients, about 25%, respond to high doses of calcitriol, 125-divitamin D, a compound known to stimulate osteoclasts. Some therapeutic success has been achieved with interferon gamma, a compound which stimulates osteoclast superoxide. Enough for osteopetrosis. Osteopoikilosis. One of my residents came with an x-ray of the hip. He said, "Look, doc, look at this patient. This patient has synovial chondromatosis, and we need to remove and do a complete synovectomy." On looking at the x-ray, it was not synovial chondromatosis. It was multiple inostosis within bone, presenting as this speckled osteoblastic pinpoint appearance. Just like a single inostosis, these are multiple forms. Osteopoikilosis is another hereditary bone disease that causes increased bone density. Unlike the diffuse or fusiform radiodensity of most other sclerosing bone dysplasias, osteopoikilosis, also known as spotted bone disease, is characterized by multiple discrete round or oval radiodensity. Each locus is an inostosis, a bone island, a common isolated lesion of bone. It is very different from a synovial chondromatosis. In osteopoikilosis, hundreds of these lesions are symmetrically clustered in the epiphyseal and metaphyseal regions throughout the skeleton, within the skeleton. Osteopoikilosis is transmitted as an autosomal dominant condition. Osteopoikilosis seems to be a result of focal disordered bone remodeling. It is asymptomatic. Cases are usually discovered incidentally during radiographic examination for other reasons. Some patients with osteopoikilosis have a hereditary dermatologic condition called dermatofibrosis lenticularis descendens. This skin condition is characterized by multiple small subcutaneous or dermal fibromas. The association of these skin lesions with osteopoikilosis suggests an underlying connective tissue disorder. These are the skin lesions. It's characterized by certain fibromas with a redness diffuse appearance, as we have in this photograph. This shows you the nodules which are present just underneath the skin. This is another close-up view of the dermal lesion. Radiographically, each osteopoikilotic focus is an oval or lenticular, small density from 0.5 to 1.0 centimeters in maximum diameter. Like a bone island, each focus is either sharply circumscribed or has radiating bone spicules which blend with the surrounding trabeculae. It's within bone. Usually each focus is confluent with the endosteal cortex. Importantly, the radiodensities are scattered symmetrically throughout the skeleton, a feature which helps distinguish this disease from metastatic osteoblastic carcinoma. Plain radiographs of an osteopoikilosis is shown over here. It consists of radiodense foci, and these are symmetrically distributed throughout the pelvis and proximal femurs. The histologic features of each osteopoikilotic focus are identical to an isolated inostosis. A condensation of dense, compact bone is present in the spongiosa. The bone is lamellar and shows evidence of remodeling. Also, haversian systems may be present. Another condition, which is called melorheostosis. Please keep these in mind because you get x-rays in staff meetings. People kind of wondering when they show an x-ray like this, is this a tumor or is it not? Is this a hereditary condition or not? Is this a finding that we can see in dysplasias or not? Is it present in osteomyelitis or not? You have to know these conditions. So now we're going to talk on melorheostosis. Melorheostosis is a disorder characterized by irregular cortical hyperostosis, which follows the long axis of a bone, often for its entire length. Usually, multiple bones in the same extremity are involved. Multiple bones in the same extremity. This would fit more or less towards the diagnosis. In addition, the skull, the spine, the pelvis, and ribs are sometimes affected. This is a plain radiograph of the fibula. A stream of periosteal new bone flows down the shaft of the fibula. As a matter of fact, it is like a dripping wax on the bone. If you look at this, my goodness, what does this patient have? Does he have Paget's disease? Does he have a malignancy? You have to learn to put a differential diagnosis. Sometimes ossification even occurs in the skin and soft tissue overlying involved bones. In addition to periosteal ossification, the patient's skin is often tight and shiny, and soft tissue fibrosis results in joint contractions. This disorder occurs sporadically, and no genetic factors have been identified. Because the hyperostosis appears to follow dermatomes, a neuropathic etiology has been postulated. Melorheostosis occurs in both children and adults. The usual presentation in childhood is a painless contraction before the age of 6. Pain does not develop until late adolescence. Flexion contractions of the knee is most common, followed by ankle, hip, and fingers. They end up by having a flexion contraction. Children may also present with leg length discrepancy due to premature closure of the epiphyseal plate on the affected side. Pathologically, the cortical hyperostosis is due to periosteal new bone deposition, which gradually matures into mature lamellar bone with Haversian system. Treatment of melorheostosis is supported. Surgery to release flexion contractions is often unsuccessful due to the severity of the soft tissue fibrosis. The pain responds somewhat to analgesics. Now we come to neuromuscular syndromes in children. The word syndrome, what does it mean? It's derived from the Greek word meaning run together. A syndrome is run together, and patients who are affected by musculoskeletal syndromes have a constellation of clinical findings that define each condition. Numerous syndromes are affected in the musculoskeletal system. As such, it is useful to group them into classes. Okay? As more is learned about the underlying genetic causes of syndromes, they can be categorized according to the function of the causative gene. The various conditions can be broadly classified into those caused by mutation in genes encoding one of the following types of proteins: structural proteins, proteins that regulate developmentally important signaling pathways, proteins implicated in neoplasia, proteins that play a role in processing biomolecules such as enzymes, and proteins that they play a role in nerve or muscle function. Syndromes within each broad group share similarities in the mode of inheritance and clinical behavior. Speaking about disorders caused by structural genes, connective tissues, bones, articular cartilage, ligaments, and skin play an obvious critical role in the skeleton. Structural proteins support these tissues, and mutations in genes that encode for these proteins disrupt the structural integrity of the tissues in which they are expressed. In these conditions, lethal structural defects may be present at birth or minor manifestations in a phenotype way evolve with time. Because the structural components are abnormal, deformity often recurs after surgical correction. The phenotype of the condition depends on the tissues involved. When the mutation is in a protein expressed in cartilage, growth abnormality may be caused by physical mechanical failure. When a protein in a ligament or tendon is affected, joints may subluxate. There can be substantial heterogeneity in the severity of a phenotype, depending on the exact way in which the mutation alters protein function. Life expectancy is normal in patients with mild disease. However, in patients with severe disease, life expectancy may be shortened because of secondary effects on vital organs. These disorders, such as osteogenesis imperfecta, multiple epiphyseal dysplasia, and Marfan's syndrome, tend to be inherited in an autosomal dominant manner. What are these disorders? Disorders caused by tumor-related genes. Several proteins and cell signaling pathways regulate cell growth and death. Mutations in these genes can activate proteins that cause cells to proliferate or inactivate proteins that normally suppress cell growth. Conditions in this category can be autosomal dominant. However, some conditions are caused by mosaic somatic mutations, in which not all the cells in the body are mutated. In some instances, when a single copy, one of the two alleles of a gene is mutated, the result is an overgrowth phenotype, whereas when the second copy, the other allele, becomes mutated in a somatic manner, the result is a tumor. Because these mutations cause tissue overgrowth, recurrence is frequent after surgery because the genetic defect that causes the overgrowth still is present. Let us come to such examples. Neurofibromatosis, von Recklinghausen disease. You can see all the lesions that one can have. Axillary freckles, café au lait macules. You can have multiple fibromas or neurofibromas. You can have involvement of the skin, hand, and the spine later. It is a complex, multi-system human disorder caused by the mutation of neurofibromin 1. This is a gene on chromosome 17. that is responsible for the production of a protein, neurofibromin, which is needed for normal function in many human cell types. Neurofibromin 1 causes tumors along the nervous system, which can grow anywhere on the body. Neurofibroma 1 is one of the most, I will call you later, Dr.J. I'm giving a lecture. Neurofibroma 1 is one of the most common genetic disorders and is not limited to any person's race or sex. Neurofibroma 1 is autosomal dominant disorder, which means that mutation or depletion of one copy or allele of neurofibroma 1 gene is sufficient for the development of neurofibroma 1, although presentation varies widely and is often different even between relatives affected by neurofibroma 1. Neurofibroma 1 causes tumors along the nervous system, which can grow anywhere on the body. It is one of the most common genetic disorders and is not limited to any person's race or sex. It is an autosomal dominant disorder, which means that mutation or deletion of one copy or allele of the neurofibroma 1 gene is sufficient for the development of neurofibroma 1, although presentation varies widely and is often different even between relatives affected by neurofibroma 1. Neurofibromatosis 1 is an age-specific disease. Most signs of neurofibromatosis 1 are visible after birth, during infancy, but many symptoms of neurofibromatosis 1 occur as the person ages and has hormonal changes. Neurofibromatosis 1 was formerly known as von Recklinghausen disease after the researcher who first documented the disorder, Friedrich Daniel von Recklinghausen. The severity of neurofibromatosis 1 varies widely, and little is known about what causes a person to have more severe or less severe symptoms. Even within the same family, as there is a 50% chance that a parent will pass their condition to their offspring. Levels of severity can vary enormously. However, 60% of people with neurofibromatosis 1 have mild cases with few symptoms that have very little effect in their day-to-day lives. About 20% of neurofibromatosis 1 patients have moderate cases with several symptoms that have little more than cosmetic effects. The other 20% have severe cases with several symptoms that affect the person's quality of life. Even in the last group, symptoms are rarely life-threatening. The progression of the condition is as follows. Congenital musculoskeletal disorders may or not be present. Cutaneous conditions may be observed in early infants. Small tumors may arise in the retina, which can eventually lead to blindness. Also, leash nodules may grow on the iris, but these are harmless. Learning disabilities may arise in preschool children. Neurofibromas may occur and can sometimes cause many dependent neurological conditions and cutaneous and skeletal disfigurement, depression, and social anxiety may occur as a result of disabilities caused by the condition. Neurofibromas may, in 8 to 13% of cases, transition into cancer, which can be fatal. In neurofibromatosis 1, there can be a generalized abnormality of the soft tissues in the fetus, which is referred to as mesodermal dysplasia, resulting in maldevelopment of skeletal structures, meningocele, and formation of cystic diverticula of the dura of the spine unrelated to spina bifida. Disorders affecting the spine include, this is what concerns us, radiography shows that dural ectasia can lead to scalloping of the posterior vertebral bodies and to the formation of cystic diverticula of dura of the spine. This may result in temporary or permanent loss of the lower extremity, sensory motor function. Focal scoliosis and kyphosis are the most common skeletal manifestations of neurofibromatosis 1, occurring in 20% of patients. And around 20% need surgery, 20 to 25%. The clinical findings in people of neurofibromatosis 1 include reduced skeletal muscle size, reduced exercise capacity, muscle weakness. The most recent study reports between 30 to 50% reduced upper and lower limb muscle strength in neurofibromatosis 1 children compared with matched controls. Facial bones and limbs, they have bowing of a long bone with a tendency to fracture and not heal, yielding a pseudoarthrosis. The most common bone to be affected is the tibia, causing congenital pseudoarthrosis of the tibia. Congenital pseudoarthrosis of the tibia occurs in 2 to 4% of individuals with neurofibromatosis 1. Treatment includes limb amputation or correction by Elizarov method as limb-sparing technique. Malformation of the facial bones of the eye sockets, lambdoid suture defects, sphenoid dysplasia. One of the most difficult findings is in these cases when you have a pseudoarthrosis of the tibia resulting from an insufficiency fracture of multiple neurofibromas at the junction of the middle and distal third of the tibia. They will have anterior lateral bowing, and these lesions don't heal. They require several procedures, and quite a few end up having a below-knee amputation. Unilateral overgrowth of a limb. When a plexiform neurofibroma manifests on a leg or arm, it will cause extra blood circulation and may thus accelerate the growth of the limb. This may cause considerable difference in length between the left and the right limbs. To equalize the difference during childhood would be by epiphysiodesis, where growth at the epiphyseal plate is halted. It can be performed on one side of the bone to help correct an angular deformity, or on both sides to stop growth of that bone completely. The surgery must also be carefully planned with regard to timing, as it is non-reversible. The goal is that the limbs are at near equal lengths at the end of growth. The skin, flat pigment lesions of the skin, cafe au lait spots, are hyperpigmented lesions that may vary in color from light brown to dark brown. This is reflected by the name of the condition, which means coffee with milk. The borders may be smooth or irregular. These spots can grow from birth and can continue to grow throughout the person's lifetime. They can increase in size and numbers during puberty and during pregnancies. They are present in both 99% of European origin and in about 93% of Indian origin. Freckling of the axillae or inguinal region, dermal neurofibroma manifested as single or multiple firm, rubbery bumps of varying sizes on a person's skin. Age of onset is puberty, progressive in number and size. They are not malignant, and they can be treated with CO2 laser or by removal by a plastic surgeon specialized in neurofibromatosis 1. The eye disease, you have lace nodules in the iris, optic nerve gliomas along one or both optic nerves, or the optic chiasma can cause bulging of the eyes, involuntary eye movement, squinting, and or vision loss. Treatment may include surgery, radiation, plus one steroids, or chemotherapy in children. This child has an optic glioma of the nerve. You can see the whole eyeball is pushed forward. Neurofibroma conditions are progressive and include plexiform neurofibroma, often congenital. Lesions are composed of sheets of neurofibromatosis tissue that may infiltrate and encase major nerves, blood vessels, and other vital structures. These lesions are difficult and sometimes impossible to routinely resect without causing any significant damage to surrounding nerves and tissue. Solitary neurofibromas affecting 8 to 12% of patients with neurofibromatosis 1. This occurs in the deep nerve trunk. The diagnosis is a cross-sectional imaging, computed tomography, or magnetic resonance. And this shows as a fusiform enlargement of a nerve. Schwannomas. These are peripheral nerve sheath tumors. They are at the periphery, which are seen with increased frequency with neurofibromatosis 1. The major distinction between the schwannoma and the solitary neurofibroma is that a schwannoma can be resected while sparing the underlying nerve, whereas resection of a neurofibroma requires sacrifice of the underlying nerve. Nerve root neurofibromas, bones, especially the ribs, can develop chronic erosions secondary to these neurofibromas from constant pressure of the adjacent neurofibroma or schwannoma on bones. Similarly, the neuroforamina of the spine can be widened and can give you a dumbbell appearance due to the presence of nerve root neurofibroma or schwannomas. Surgery may be indeed needed when neurofibroma, one related tumors compress organs or other structures. Dural ectasia in the spine within the central nervous system, neurofibromatosis 1 manifests as a weakness of the dura, which is the tough covering of the brain and spine. Weakness of the dura leads to focal enlargement due to chronic exposure to the pressures of CSF pulsation, typically presents as paresthesia or loss of motor or sensory function. Dural ectasia, again, it has been shown that dural ectasia occur near plexiform neurofibromas, which may be infiltrative, leading to weakening of the dura. Acetazolamide has shown promise as a treatment for this condition, and in very few cases do dural ectasia require surgery. Neurofibromatosis is the most common single gene disorder in humans, and neurofibromatosis type 1 is the type most frequently encountered by orthopedic surgeons. The diagnosis is based on clinical findings which are not usually apparent until later in life, often in the pre-teen years. At least two of the following cardinal clinical findings are essential. Café au lait spots in children, when less than 5 millimeters, it occurs in a child, and in adults, it's more than 15 millimeters. So you have to think of freckling in the axillae, and think of optic gliomas and lesion nodules in the iris, optic gliomas in the retina. All these one should consider, and vertebral scalloping and cortical thinning. All these are correct. So don't forget, neurofibromatosis is caused by a mutation in neurofibromatosis 1 gene. Its protein product, neurofibromin, acts as a tumor suppressor. Neurofibromin is expressed as at higher levels in neurocrest during development, and these cells migrate to the common sites of abnormalities in the disorder. Two recently reported approaches to treat the bone-specific phenotypes target pyrophosphate, which accumulates at high levels of bone. This could be corrected by using asfotase enzyme therapy. The latter is replacement of alkaline phosphatase. And the other approach is to target pre-catenin signaling, which is hyperactive in osteogenesis in neurofibromatosis, preventing bone formation. Inhibiting its activity improves bone repair. However, clinical studies are required to determine the efficacy of these approaches. Scoliosis in neurofibromatosis is a topic that we take into serious consideration in spine by us spine surgeons. The orthopedic manifestation of neurofibromatosis includes scoliosis, overgrowth of limbs, and pseudoarthrosis of the tibia. Scoliosis is common, and curves can be either dystrophic or idiopathic. Dystrophic scoliosis is associated with a short, sharp, single curve. It is associated with deformity of the ribs and vertebrae, with dural ectasia and rib penetration of the spinal canal. The onset is early in childhood, and it is relentlessly progressive. What is characteristic about the dystrophic? Look at the ribs. They are pencil. They are under pressure. They are pencil appearance, thinner, like a pencil. The curve is acute. Look at this curve on the left-hand side. It is acute. It is severe. There's a strong element of rotation and deformity. These are very difficult to correct. Curves in children younger than 7 years have almost a chance of becoming dystrophic later in life. The most important risk factors for progression are in early age of onset, a high top angle, and an apical vertebra that is fairly rotated, scalloped bone, concave loss of bone in the middle to lower thoracic area. Dystrophic curves are refractive to brace treatment. Don't bother giving your patients brace. They don't respond. Either spinal deformities such as kyphosis also can occur. In severe cases, the scoliosis has so much rotation that curve progression more obvious on lateral rather than anterior-posterior radiograph. In those with severe angular kyphosis, a high risk of paraplegia is present. Pseudoarthrosis of bone can occur and most frequently affects the tibia, as I mentioned previously. Tibial dysplasia with characteristic anterolateral bone, which in infancy can progress to pseudoarthrosis. And this is associated with neurofibromatosis type 1. The characteristic anterolateral bone that is obvious in infancy often progresses to a fracture, with spontaneous union being rare. Hamartoma or undifferentiated mesenchymal cells occurs at the pseudoarthrosis site, which sometimes is associated with loss of normal allele of the neurofibromatosis gene. Pharmacologic approaches to pseudoarthrosis in neurofibromatosis have been reported. A mouse model suggested rovastatin, but human studies of this approach are needed. Direct instillation of bone morphogenic protein to pseudoarthrosis site may help to achieve union, but variable results have been reported, and it is not known if the use of bone morphogenic protein in patients with inherited pre-malignant condition has long-term consequences. The incidence of malignancy in neurofibromatosis is reported to range from less than 1% to more than 20%. The most common tumor location is in the central nervous system, with lesions such as optic nerve glioma, caustic neuroma, and astrocytoma. Malignant degeneration of a neurofibromatosis, or at least neurofibroma, to a neurofibrosarcoma is erased. This process can occur in the central or peripheral neurofibroma. It can be quite difficult to distinguish a malignant lesion from a benign lesion. CT scans show areas of low enhancing density in neurofibrosarcomas, but no studies have confirmed the sensitivity and specificity of this finding. Similar patterns also can be visualized using MRI. Routine surveillance for sarcomas or sarcomatous lesions change is impossible because of large numbers of neurofibromas present in the individual. In children with a neurofibroma, the propensity exists for the development of other malignancies, such as Wilms tumor or rhabdomyosarcoma. Proteus syndrome. This is an interesting thing. They either have long fingers, deformed fingers. This is a photograph on a patient with Proteus syndrome. Proteus syndrome is an overgrowth disorder caused by a rare genetic mosaicism. I'll tell you something. I was preparing this lecture when 2 days ago I received a patient from the north of Lebanon whose family was totally involved having Proteus syndrome. So one should not say that this is rare. We do see that. It's a genetic mutation during embryonic development. It gives rise to overgrowth in a subset of individuals. Look at this child. He looks normal, but look at his hand on the right-hand side. He has overgrowth and totally abnormal. The feet, the bottom of the feet look just like the brain in Proteus syndrome. The hands are involved. You see there's overgrowth, some fingers are absent, etc. And look at the feet of multiple patients with Proteus syndrome, just like the brain. These are the deformities one could have. Both hemihypertrophy and macrodactyly are present. A mosaic distribution of lesions, a progressive course, and sporadic occurrence are characteristics required to make the diagnosis. Symptoms worsen as time progresses, but unlike other overgrowth syndromes, an increased incidence of malignancy has not been reported. Hemangiomas, pigmented nevi, and subcutaneous lipomas are present in the skin. A somatic mosaic mutation, mutant only in involved cells, activating ACTI, is associated with Proteus syndrome. The ACTI gene helps control cell growth and division. A mutation in this gene disrupts the cell's ability to control its own growth. This allows the cell to grow and divide abnormally, leading to overgrowth traits seen in Proteus syndrome. Spinal deformity, including scoliosis, kyphosis, and large vertebral bodies, known as megaspondylodysplasia, can be present. Angular malformations of the lower extremities, especially ginovalcum, are common along the regional gigantism. Look at the vertebral bodies. You see that there are certain vertebral bodies which are larger than others. Okay? And you can see the deformities present, secondary to irregularity in the sizes of the vertebral bodies. Recurrence after surgical intervention is very common. Just like a malignancy, when you remove it, it regrows. And likely is caused by an underlying growth advantage in affected tissue that cannot be corrected surgically. Osteotomies can correct angular malformation, but the decision to undertake surgical correction must consider the possibility of rapid recurrence of the deformity after corrective surgery. The use of growth modulation, for example, 8-plate orthofix to manage limb angular deformity is promising. It is a promising approach, but published results are lacking. Nerve compression can be managed with decompression, but on the other hand, if the spinal cord compression exists, it is difficult to decompress it, if not impossible, to successfully treat surgically because of the vertebral overgrowth. Disorders caused by developmentally important signaling pathways. Gene expression and cell signaling pathways are regulated in a coordinated manner for cells to proliferate, move, and die, allowing an organism to pattern normally and develop into an adult. Mutations in the genes that regulate these processes will alter normal development, causing disturbances in growth or pattern. Shape changes in the skeleton. Surgery is to correct issues such as limb malalignment are usually successful. Manifestations frequently occur in other organ systems because the genes that play roles in skeletal development also play important roles in the development of other organs. These disorders are usually inherited in an autosomal dominant manner, although the inheritance pattern is variable. Many of these disorders are caused by mutations, dysregulating the way growth plate chondrocytes function, and knowledge of the growth plate defect helps physicians understand the associated clinical manifestation. Camptomelic dysplasia. You see, this is a dysplasia which is characterized by angular deformities and insufficiency fractures. So it's a genetic disorder characterized by bowing of the long bones and many other skeletal and extraskeletal features. It can be lethal in the neonatal period due to respiratory insufficiency, but the severity of the disease is variable and a significant proportion of patients survive into adulthood. The name is derived from the Greek root campo or campto. This means bent, campo or campto, bent. And melia means limb. An unusual aspect of the disease is that up to 2/3 of affected individuals have 46XY genotypic males display a range of disorders of sexual development and genital ambiguity, or may even develop as normal phenotypic females, as in complete 46XY sex reversal. While the definitive presentation of the disease is a patient having bowed lower limbs and sex reversal in 46XY males, there are other clinical criteria that can be used absent these characteristics to make the diagnosis. Sex reversal is a biological process whereby the pathway directed towards the already determined sex fate is flipped towards the opposite sex, creating a discordance between the primary sex fate. Patients may present with shortened and angulated lower limbs, a vertically oriented and narrow pelvis, an enlarged head, an undersized jaw, cleft palate, flat nasal bridge, low set ears, and club feet. You can see that the shoulders are underdeveloped. The blades or the scapulae are underdeveloped. Dislocated hips do occur. Hypoplastic vertebral pedicles in the thoracic region exist. There are 11 pairs of ribs instead of 12. Kyphosis of the cervical spine is present. This shows you the various problems that occur with these patients. Respiratory distress can be caused by an underdeveloped trachea, which collapses on inhalation, or by insufficient rib cage development. This is a child with camptomelic dysplasia. You see the head, it is large. You can see it. You can see, look at the leg on the right-hand side. It's angulated. There is bowing. It's curved. Camptomelic dysplasia is caused by a mutation in the SOX9 gene, which regulates the differentiation of mesenchymal cells to chondrocytes. Although the endochondral process is normal, the number of cells undergoing this process is not appearing to result in an abnormality in the formation of the cartilage analogy during fetal development. Since the camptomelic disorder is autosomal, only one copy of the SOX9 gene needs to have the mutation for a person to have the disorder. The other copy works normally, but is not sufficient to prevent the person from having the disorder. For this reason, camptomelic dysplasia is a severe form of short-limb dwarfism that it is sometimes fatal. The long bones, primarily the tibia and femora, are bowed. Defective tracheal and lower respiratory tract cartilage may cause respiratory failure in the neonatal period. Laryngotracheomalacia. They usually have a large head. They have rubbing of the feet. They have difficulty in breathing. They have a recessed mandible. They have a large tongue. These are the distinctive features of laryngotracheomalacia. Small chin, prominent eyes, flat face. They have a progressive spinal deformity, kyphosis, and scoliosis, which further compromises pulmonary function. And this is common and leads to death if it is untreated. Hydromyelia and diastematomyelia have been reported, and neurologic complications and pseudoarthrosis after spinal treatment are common. Other clinical features include flattened head, palate, migrainaceae, defects of heart, kidneys, and C reversal. These are deformities that occur in this condition. And the SOX9 gene is required for the development of male external genitalia. Disorders of multiple genes, I will go very rapidly. Don't forget about Down syndrome. You have simian lines. You have trident fingers. Down syndrome is the most frequent trisomy, and its incidence increases with maternal age. Most patients have 3 copies of chromosome 21. 4% have a translocation involving this chromosome, and 1% are mosaic with some normal cells. This shows you the trisomy 21. Many features attributable to Down syndrome are found in specific chromosomal regions, including hypotonia, joint hyperlaxity, with abnormalities in the upper cervical spine, atlantoaxial, and occipital atlantal. Patients have relatively short stature, a flat face, and varying degrees of mental retardation. Acetabular dysplasia or hip dislocation occur in 5% of patients aged 2 to 10 years, and slip capital femoral epiphysis and osteonecrosis often are present. Wide variability in acetabular version occurs, which must be taken into account to effectively reconstruct the hip. Other common characteristics include short, broad hands, patellofemoral instability, flat foot, and hallux valgus, congenital heart defects, and thyroid dysfunction. Orthopedic surgeons and pediatricians often are asked to evaluate children with Down syndrome to confirm their eligibility for participation in the Special Olympics. This shows you, look at this finger, the small finger is short. You can see the rest of the fingers. You can see the simian line, simian crease, Sydney line, normal palm creases. Look at the fingers. They have hallux valgus, and there's a space between the second toe and the thumb. A broad variety of radiographic abnormalities of the cervical spine are present, but radiographic findings often do not correlate with the symptoms. In addition, a high complication rate associated with cervical spine fusion occurs in Down syndrome. It is not clear how to best manage children who are asymptomatic but have radiographic abnormalities. Modern instrumentation techniques can decrease but not eliminate the associated complication rate. For children who want to participate in the Special Olympics and are asymptomatic but have radiographic findings, the most prudent approach is to have these children avoid tumbling activities. Briefly about Turner syndrome. It is a monosomy of X chromosome. There's an X or X0. There is no double X. 1 in every 5,000 births. Varied degree of effects. They have a webbed neck, they have a short stature, and immature sterile females. This shows you the end result. Turner syndrome is caused by a complete or partial absence of one of the X chromosomes, and it can occur only in women. A lack of this chromosome, males, is incompatible with life. Clinical features include short stature, a wide webbed neck, low set ears and hairline, cubitus and genu valgum, swollen hands and feet, scoliosis, and a broad, flat chest shaped like a shield. These are the characteristics of these lesions. They have special coarse facial features, they have curly hair, they have a wide forehead, they have a protruding chin, and they have webbing of the neck. And they have a pectus excavatum. So the symptoms of Turner syndrome is, in a female, tend to be shorter than average. They have web-like necks, poorly developed breasts, and immature internal sexual organs. They have a reduced ability to interpret spatial relationships and are usually infertile. Females are often sterile as they may not menstruate or ovulate. Subnormal intelligence with many male characteristics such as heavy neck muscles and narrow hips. Patients usually experience gonadal dysfunction, which results in absent or incomplete development of puberty, infertility, diabetes, increased weight, and osteoporosis. Additional observations include congenital heart disease, kidney abnormalities, and cognitive deficits, specifically in memory, visual, spatial, and mathematical areas. Life expectancy is normal. Noonan syndrome often is confused with Turner syndrome because both share several clinical characteristics. Noonan syndrome equally affects both males and females. 10 types have now been identified. They have similar phenotypic features, but different causative genes. All but one form type 2 and is autosomal dominant. The principal features of Noonan syndrome include congenital heart defects, short stature, cervical spine fusion, low set ears and hairline, scoliosis, pectus carinatum or excavatum, impaired blood clotting, and learning disabilities with hypotonia. Noonan syndrome is one of the common syndromes associated with congenital heart defects. Some patients have severe joint or muscle pain, often with no identifiable cause. Arnold-Chiari malformation type 1 has been noted in some patients. The Prader-Willi syndrome. The PWS is a complex genetic disorder that typically causes low muscle tone, short stature, cognitive disability, problem behaviors, and chronic feeling of hunger that can lead to excessive eating, and they become so fat. PWS is caused by a partial deletion of the 15th chromosome involving a group of genes when the chromosome is inherited from the father. The distinction of chromosomes by paternal origin is the result of imprinting. Thus, Prader-Willi has a sister syndrome called Engelmann syndrome that affects maternally implanted genes in the region, diagnosed by DNA-based methylation testing to detect the absence of paternally contributed region. They have a paternal long arm of chromosome 15 deletion. They have mental deficiency, which could be mild or moderate. They have a normal birth size. They have decreased growth rate. They have a short stature. They are obese and can be very obese. They have very small hands, feet, and genitalia. They have fair skin, blue eyes, and sun sensitivity. Craniofacial, almond-shaped, narrow bifrontal diameter. It is characterized by hypotonia, short stature, that responds to growth hormones therapy, and a failure to thrive in the early years, which is followed by an extreme and insatiable appetite, often resulting in morbid obesity, hypogonadism, and mild mental retardation. Orthopedic manifestations include scoliosis, which affects up to 90% of patients, small hands and feet, and joint hyperlaxity. Patients with Prader-Willi syndrome have complications from surgery secondary to an abnormal physiologic response to hypercapnia and hypoxia, obstructed sleep apnea, thick pulmonary secretions, obesity, prolonged exaggerated response to sedatives, and increased risk for aspiration. Growth hormone therapy is used in this disorder, which results in improvements in weight and behavior. The effect of growth hormone therapy on skeletal deformity is unclear, but the results of a recent randomized control trial suggest that it does not negatively affect the sequelae of spinal deformity. Briefly about trichorhinophalangeal syndromes. There are two types. Type 1 and type 2 are caused by either mutation or loss of TRPS1 gene. However, TRP type 2 has a larger loss of the chromosome region with loss of adjacent EXT1 gene, responsible for hereditary multiple exostosis. Hips mimic leg calcifications disease in both radiographs and symptoms. The key distinguishing feature for TRP type 2 is the presence of multiple exostoses, especially involving the lower extremities. Langer and Gideon TRP type 2 syndrome causes cone-shaped epiphyses of the phalanges of the hands and short fingers and toes. The fifth fingers are sometimes bent. Skeletal abnormalities not affecting the hands and feet may also occur. These include winged scapula, thin ribs, and scoliosis. In addition, individuals with Langer-Gideon syndrome may develop hip problems similar to those of leg calciferous disease, such as progressive degeneration of the head of the femur. As affected individuals age, they often develop benign bony overgrowth or growth, exostosis, which project off the surfaces of the bones. Depending on the location of the exostosis, they cause numerous complications such as compression of the spinal cord, asymmetric growth of the limbs, and reduced mobility. Langer-Gideon syndrome initially causes joint hypermobility. This progresses to joint stiffness later in life when osteochondromas begin to develop, typically between infancy and mild childhood, which decreases mobility. Hip dysplasia may be present, usually developing in early childhood, although it can occur in infancy or childhood. The majority of individuals with Langer-Gideon syndrome have sparse scalp hair. This particularly is severe in males who often experience alopecia shortly after puberty. Despite this, the eyebrows may be unusually thick. The syndrome occurs when a small piece of chromosome 8, long arm, which contains a number of genes, is missing. The loss of these genes is responsible for some of the overall characteristics of Langer-Gideon syndrome. The missing portion of the chromosome is 8q23.2, q24.1. This region includes genes of TRPS1 and EXT1. Note the broad nasal bridge and the tip without broadening of the nasal bridge. The alae of the nose are underdeveloped. The columella is wide and low hanging. The philtrium is smooth, and there's some medial flaring of the eyebrows. The hands of a woman aged 21 years, note the metacarpal shortening and ulnar deviation of the third fingers and radial deviation of the fourth fingers with short thumbs. Frontal radiograph of the hand of a male aged 4 years, note the coned epiphyses of the third to fifth proximal phalanges. Phalanges and more subtle partial fused coned epiphyses of the second to fourth middle fingers or phalanges. This shows you a residual angle deformity of the proximal aspects of the second and fifth middle phalanges related to fusion of prior cone-shaped epiphyses. This shows you an exostosis of the humerus, especially in the type 2. This causes exostosis. Patients have pear-shaped bulbous nose, prominent ears, sparse hair, cone epiphysis, and short lateral metacarpals. They also have mild mental retardation. Skeletal manifestations are specific to the epiphysis. Disorders caused by protein processing genes. Enzymes modify molecules or other proteins. The enzymes implicated in musculoskeletal pathology often modify substances for degradation. Thus, these conditions often are associated with cell dysfunction because of the accumulation of these substances. The excess accumulation of proteins in cells causes them to become larger than normal, and the increase in space occupied by these large cells can mimic increased pressure on bones and osteonecrosis. They also can cause increased extradural material on the spine and potentially resulting in nerve compression. Accumulated cellular byproducts can biologically active or often resulting in bone and joint diseases and autoimmune diseases. Multiple systems are nearly always involved in these disorders. Medical treatment to replace the defective enzyme have been developed for many of these disorders. Early diagnosis and appropriate medical treatment are slowly decreasing the number of individuals who have musculoskeletal problems. Most enzyme disorders are inherited in an autosomal recessive manner. So, in summary, various orthopedic syndromes are caused by genetic mutation or fetal environment factors that alter cell behavior, often in a manner that mimics genetic mutation. An understanding of the genetic etiology allows the classification of syndromes based on function of the causative gene product. Structural proteins, proteins that regulate developmentally important signaling pathways, proteins implicated in neoplasia, and proteins that play a role in the processing of molecules, such as enzymes, proteins that play a role in nerve and muscle function. Each class of syndromes shares common clinical findings and the responses to treatment. So your take-home message, you should know about the genetic cause of a syndrome, and this can explain the phenotype and predict treatment outcomes. Syndromes caused by mutations in genes encoding proteins that regulate cell growth can predispose individuals to cancer. Disorders caused by mutations in genes encoding for enzymes tends to be autosomal recessive, and enzyme replacement therapy typically arrests but does not fix the skeletal deformity. Syndromes caused by large chromosomal abnormalities, such as a trisomy, are not inherited. Overgrowth conditions can be caused by mosaic or somatic mutations. I thank you very much. إن شاء الله ما زهقناكم يا جماعة. Sure. Any questions? Are there any questions? ما عم بسمع. علوا صوتكم. ايه؟
الكل مستمتعين تمام. دكتور جون السبجكت كومبليكيتد والكل مستمتعين، ما في سؤال يعني. as you know the enzymatic disorder are very rare, and so the knowledge you take today is very nice.
بس أنا بدي أقول لك شغلة. It is very important for them to know about it.
Yes,
You'll find that there are some questions in board exams on this topic.
Yes, yes.
And if you recall, Dr. Khalid, I requested that pediatricians be present. A good portion of this should be known by the pediatrician and also by the pediatric orthopedic surgeon. Many patients go around from doctor to doctor trying to know what they have.
Yes.
I'll tell you something. There was a patient who had the iliac horn syndrome, where the patient had recurrence of dislocation of the patella. Patient had iliac horns and had multiple deformities. They did not know what the patient had. When I saw him, and not that I know about it. No, it's because I read a lot about it and I know about it. And me being an orthopedic surgeon should know about these things. I'll tell you, for instance, how many people have had cases of neurofibromatosis? I've asked people with who know receive patients. I asked them, pseudoarthrosis is most common of which type of neurofibromatosis? They didn't even know that type 1 was associated with it. Another point is when you get the scoliosis, and if you see that it's a dystrophic form of scoliosis, you should search for it and make sure that this patient does not have neurofibromas in the canals, giving you a dumbbell appearance, because this can be very resistant to treatment. You have to know these, and this is part of pediatric orthopedic surgery. And this is what we are giving now. If I don't give this at present, it means that I give you an insufficient course on pediatric orthopedic surgery. Well, thank you very much for bearing with me. It's a boring topic. It's a difficult topic. But gene therapy has become very popular these days. Thank you very much.
Thank you very much. Thank you very much.
شكرا جزيلا دكتور جسم جميع الطب العظام، نشكرك على هذه المحاضرة الرائعة.
Thank you.